everyone. I am presenting on topic diabetic retinopathy in relation to cataract surgery on behalf of Dr. Sandhya Makhija. Diabetic mellitus is on rise across the world, 150 million people. 20% of the world diabetic are Indian. 12% of people living in Indian metros suffer from diabetes. 40% more are in pre-diabetic stage, striking the young. More common in diabetes, 2 to 4 times higher risk, one of the major cause of visual loss. Cataract surgery has been accused for causing rapid progression in severity of diabetic retinopathy. Macular edema, common cause for poor post-operative visual gain. More than 90% of patients with diabetic mellitus without retinopathy attained a final visual acuity of 20 by 40 or better. Patients with NPDR but no edema also have outcomes similar to non-diabetics. Patients with macular edema with or without proliferation have worse outcome. Now the difference between CSME and CME. In CME, increased permeability due to inflammation. Diabetic pathology causes increased permeability in CSME as well. The course of CME tends to improve with time, but in CSME it tends to progress. Spontaneous resolution is unlikely. Clinical presentation of CME is mild NPDR changes, absence of hard exudate, absence or minute dot linear hemorrhages at macula, while in CSME diffuse focal area of edema associated with hard exudate or more moderate NPDR. The management of CME is observation, NSAIDs, and corticosteroid, while in CSME it is immediate laser post-coagulation, photocoagulation. As per Polak et al., British Journal of Ophthalmology in 1992, there is increased incidence of angiographic as well as clinical CME in diabetic mellitus. Development of CME is also influenced by presence of pre-existing retinopathy, development of retinopathy in post-operative period. Eye that had no pre-existing retinopathy has higher incidence of angiographic CME, while eye that has pre-existing retinopathy has higher incidence of clinical CME. The risk factors associated with poor visual outcomes are duration and severity of pre-existing retinopathy, poor visual acuity before surgery, need for PPV with or without tamponade, type of cataract surgery does not appear to influence outcome. Other risk factors are like age, gender, ethnicity, and BMI. Rules for pre-operative workup are good metabolic control. Complete anterior and posterior workup is required with type of cataract and other eye status. Both eye should be dilated for examination. Assessment of type of retinopathy should be done and other eye disease should be excluded. If need and enough visualization is present, then FFA and OCT can be done for the documentation. USG scan is preferred in case when visualization is not there. These are the fundus photo with their correlated FFAs. Role of laser photocoagulation before cataract surgery reported to stabilize retinopathy, but not prevent its progression. Where cataract density prevent application, laser photocoagulation as soon as cataract wound is stabilized. Laser indirect ophthalmoscope can be considered as early, may also at time increase CME risk. Fluorescence angiogram after bilateral cataract surgery in right eye, focal laser photocoagulation was done preoperatively, shows stable maculopathy postoperatively too. While in left eye, it shows progressive maculopathy requiring laser photocoagulation. Here the right eye is phakic with NPDR, while in left eye pseudophakic with NPDR with CME and early CSME. Treating DME along with cataract surgery required intravitreal anti-VEGF injection after cataract surgery. Studies proving intravitreal anti-VEGF at the time of cataract surgery improves visual outcome for longer post-operative period. Combined cataract surgery with intravitreal dexamethasone implant. Combined PPV with cataract surgery if TRD, VH or VMT is there. Good patient counseling is required, diabetic status well controlled, good surgery, complete removal of cortical matter, avoid rupturing posterior capsule, lens iris touch, vitreous adhesion to wound because of postoperative CME more common, Emphasize on minimum corneal end damage. Corneal epithelium also slow to heal. Phacoemulsification with IOL in bag is safe. Avoid ACIL or SFIOL. Large optic IOL can be used. Is a special care against of endophthalmitis is required. Good postoperative care is required. Now the summary is patient with diabetic mellitus have high risk of developing cataract. Many already have diabetic retinopathy at the time of cataract surgery. 90% patient who have no pre-existing diabetic retinopathy carry good visual prognosis. One third of patient with pre-existing diabetic retinopathy shows progression. Postoperative angiographic macular edema is common but resolves spontaneously in case of no or minimum diabetic retinopathy. While patient with moderate NPDR, CSME tend to persist and may worsen after cataract surgery. Now, the important is the good post-operative care and close observation after at least 6 months. The role of physician is also to refer the patient back to the ophthalmologist for periodic evaluation of the eye. To conclude, careful coordination between the cataract surgeon, retina specialist, and physician is necessary to avoid delay and increase complications. Thank you.